And good morning, everyone. I'm Dr. Williams, Chair of Medicine, and it is my pleasure to introduce our introducer. Our speaker this morning for Medical Grand Rounds is Dr. Joel Richter, who's an emeritus professor at Morsani College of Medicine in Tampa, Florida. And he's going to be introduced by our colleague and long-term leader, but I think he's our leader, Dr. Craig McLean, who is the professor of medicine and pharmacology and toxicology and chief of research affairs here. And he is associate vice president for health affairs and research. And he is one of our co-division chiefs in gastroenterology. And it seems that the two of them have known each other much longer than most of us have actually been around. So he's the perfect person to do the introduction of Dr. Richter. Dr. McLean?
Thank you very much, Dr. Williams. And it is a real pleasure to introduce Joel Richter as our Ground Rounds speaker today, talking about reflux disease. I was talking to Dr. Richter last week and told him he needed to send his CV over. And he said, "Well, do I have to send the whole CV?" He said, "That's over 50 pages." And I said, "Well, that means I'm going to have to be very careful on my introduction today to keep it on time." But to start with, Joel graduated from Texas A&M and received his undergraduate degree there. He received his MD degree from the University of Texas at Dallas Southwestern. He did his research residency at the National Naval Medical Center in Bethesda and did his GI fellowship there also. Dr. Richter's been on the faculty at a host of medical schools around the country and has been in leadership positions in many of those, including UAB, Bowman Gray, and I think the Cleveland Clinic. I think the highlight is probably his time at Temple, where he was chairman of medicine for almost a decade. He finished his career at the University of South Florida, where he directed the Swallowing Center, and that's a internationally recognized program. So, Joel, welcome, and we look forward to hearing about GI reflux disease 2024.
Greg, thank you for the introduction. In this modern day of Zoom, you don't know really what your audience is like, but I'm going to try to entertain you, at least some of the evolving knowledge of GERD of the last 10 years, some of the new treatments, some that have worked, some that have not worked, and make a little comment about the controversy that you may have been hearing about the proton pump inhibitor. Let's talk about probably one of the more common GI diseases of mankind. This is gastroesophageal reflux disease, which is a condition which develops when the reflux of gastric content causes troublesome symptoms or complaints. This was defined by a group of us in Montreal. You'll see names of various places throughout the world. That means, quote, the experts, and the older you get, the less likely you are to be an expert. But at that time, I was young enough to be considered an expert, and we broke up the symptoms into esophageal symptoms, the classic reflux symptoms, which would be heartburn, acid regurgitation, chest pain, reflux symptoms associated with esophageal injury, and then also the other more nebulous group, and it's still nebulous today in 2024, is the extraesophageal ones, whether or not reflux is really associated with cough, laryngitis, asthma, dental erosions, pharyngitis, sinusitis, idiopathic. Okay, let's see. All right. The other thing is the one thing that hasn't changed over all this period of time, And it was interesting when I was looking at these slides was this slide probably is 25 years old. Not that the rest of my slides are 25 years old, but still today, 60 to 70% of people with heartburn complaints when endoscoped will have a normal looking esophagus. 20 to 30% will have esophagitis. And depending on how it's defined, uh, 5 to 10% will have Barrett's esophagus.
It's funny, but it like when we see, not just he's getting into scroll. I don't know what. I mean, I told him.
Yeah.
Anyway, it's
I
like
think that someone is not on mute, perhaps Jason.
Okay, I've got some overriding. Okay. So reflux is no doubt common throughout the world, and we missed one of the slides, and I'm not going to try to go back. The interesting thing about reflux for all of us has been the different spectrums in men and women, and this has been ever since we've been studying the disease. Both men and women have the symptoms of equal frequency. Men have more erosive esophagitis, and then when you go right up the complication list of Barrett's esophagus and adenocarcinoma, that's more of a problem associated with the men than with the women. Now, then, the burden of GI symptoms in the United States is looked at in a yearly fashion in various ways and various graphs that you can use. This is a little old, but this was a little different survey of 71,000 Americans using a mobile app and asking them what their most common reflux symptom, and they said at that period of time, a heartburn and reflux was their most common symptom. This is a more sophisticated survey of office visits nationally, and this is in millions. And after abdominal pain, gastroesophageal reflux with reflux esophagitis was the by far the most common reason for office visits, about 4 million more than the next one, nausea and vomiting. And again, I continue to be amazed about a disease which is relatively mild in severity and how much symptoms it does cause the patients. It's also very expensive. It's estimated that the cost of GI healthcare expenditure in 2019 was $135.6 billion. GERD medication alone accounted for 9.1 billion. 9.1 billion, and that wasn't associated with the surgery. So not only is it a frequent problem, a troubling problem, it's also a very expensive problem. Most of our healthcare systems use omeprazole because it's the cheapest of all PPIs and just as effective as any of the others that are available. Well, what's contributing to the increase in the prevalence of GERD? Because that's the real thing. I mean, you got a preventable disease if you could put some emphasis on it. The root of all evil is the lower esophageal sphincter, and I'll talk about that in a moment. But the factors that are increasing are hiatal hernias, obesity, which is everywhere, particularly abdominal obesity, and then the interesting relationship that we studied a while back between the protective effect of H. pylori infection. That is, if you had H. pylori infection, you had less heartburn, and then if you eradicated it, you had more heartburn. So this is kind of a diagram of the various manometric pictures of the LES. At the up topper left, you see the normal lower esophageal sphincter, and then you see a phenomenon known as transient LES relaxation. This we do thousands of times a day because this is the way you get rid of the air that you have in your stomach and the way that you belch. You can also have that as a result of coughing. This is the gastric pressure down here on the bottom line and the coughing, and then spontaneous reflux. And actually, a healthy person, other than my case last night, is something that occurs when there's basically no sphincter pressure. Now, this is what the diagram looks like when you look at all comers. And in all comers, transient LES relaxation is still by far the most common manifestation. You can see from 90% to about 40%. But then when you get over the people with a bad reflux disease, those are the ones that really are refluxing because they basically have no valve. And you can see that doesn't happen in the healthy people, but it happens in the people with the bad reflux disease. Now then, what about this hiatal hernia that we hear everybody talk about? I think even the medical students have heard about the hiatal hernia. The esophagus is a muscle, and it has two components. It has the intrinsic muscle of the esophagus itself, in this diagram shown in red, and then it has the effect of the diaphragm. And you'll notice with the diaphragm is when you take in the deep inspiration, which would promote reflux, the diaphragm contracts. So you basically have that secondary muscle to protect you so that you're not refluxing every time you take a deep breath. Now, what happens with whoops, now this one I do want to get back to.
Just might try your left arrow or your up arrow.
Left arrow, up arrow. Let's see. I've been doing good with the arrow. Yeah.
So you can also right click and under the, I believe it's under the next, you should have the option.
There we go. There we go. Okay. We'll try that one too. So with the hiatal hernia, basically you have a portion of the stomach trapped between the diaphragm and the sphincter itself, and that collects the reflux, and then that reflux can reflux during the day when you don't have any LES sphincter pressure. So that's why the presence of a hiatal hernia becomes so important, as shown in my next slide. And basically, you will see in this slide, and it's a relatively old slide, but still a good slide, that from no esophagitis, where about 40% of the patients had a hiatal hernia, to esophageal strictures, where all of the patients had a hiatal hernia. That's how prominent this entity is in the disease state. Now then, it always comes up in discussions, all these various forms of hiatal hernias, and I just happen to have in one single slide a picture of these. This is over the far left is the sliding hiatal hernia, which accounts probably for about 85–90%. The type 2 paraesophageal hiatal hernia is the rarest of all hiatal hernias. In this hernia, basically you're having a little bit of the stomach slide up right next to the esophagus. You see it more after anti-reflux surgery repair done laparoscopically. And the important thing about this hernia is they do not have reflux because of the fact that a hernia has not been generated. This is actually an umbilical hernia. The next most common form of hernia is the type 3 hernia. This is the patient who presents to your office with fullness. They feel like when they're eating, it's all in their stomach. And they're right, it is all in their stomach. They also have problems with chest pain. They also have problems with breathing problems. And this is treated by reduction of the hiatal hernia. And then the fourth and rarest form of hiatal hernia is a hernia in which you have various types of organs, pancreas usually, but also colon up in the chest. Well, what about the effects of obesity in esophageal physiology? Well, the effects of obesity is still yet to be studied the way that it should, but we know that all of these factors, whether or not you're looking at the hiatal hernia, the increased intragastric pressure, the impairment that happens with the relaxation of the stomach when you eat, when you're obese, delayed gastric emptying, all these factors generate larger hiatal hernias over time, and they contribute to the reflux that we see. And again, that is one of the reasons why reflux is more severe in men. Now, then this is this interesting phenomena that we came upon serendipitously when we were looking at something else. We were looking at the function of the H. pylori when it was interested in at that time in LES dysfunction genetically and acquired, and we found none. But we did find that in people who had severe H. pylori infection, the CAG-A variety, they had atrophic gastritis. On the other hand, when you eradicated that atrophic gastritis, as you're going from here with the PPIs and antibiotics at that time, you had no gastritis, and therefore you potentially had an increase in reflux. And so that may be one of the reasons why there's an increase in reflux in a lot of the underserved countries of the world. What's the role of endoscopy in GERD in 2004? Well, throughout has always been early endoscopy, alarm symptoms, dysphagia, bleeding, odynophagia, weight loss. Also, if you're looking for esophagitis, you should do your endoscopy at least 2 weeks, up to 4 weeks off PPIs to get the best assessment of what we call the Los Angeles grading system. Again, another grading system originated from a bunch of quote experts getting together in Los Angeles, but now very well accepted as a grading system for GERD. And if you have B, C, and D esophagitis, that confirms that you have GERD. And then depending on the various criteria that are being used, and they change constantly, we need to do GERD screening for people who have Barrett's esophagus and known reflux disease. Now then, the holy grail of reflux disease has been to try to develop a device in which you didn't have to do transnasal catheterization. You still have to do that for manometry, but you don't want to wear this system around for multiple days if you don't have to. And we were finally able to, myself working with a couple of surgeons and smart people at Medtronics, were able to develop the Bravo pH probe. So this is a capsule device with a pH sensor. It's attachments to the distal esophageal mucosa, which is relatively minimally mild discomfort. I've had it myself. And then radio transmission to a pH device. Most of the time we pass it nasally during, or I'm sorry, transorally during endoscopy, and the patient's asleep, so it's basically like doing a bougie dilatation. And then here it is actually attached to my esophagus. We used to wear this around 48 hours. And the problem with the 48 hours was not the pain, and it was easy enough to bring them back, but she had a dichotomous variable in some of your patients. About 25% of your patients, you had 1 day positive and 1 day negative. And it turns out that left us with the quandary, did they really have reflux? Did they really not have reflux? That was finally answered by the group from UCLA. We had already defined that the most variable time to have the reflux on the monitoring system was during the first 24 hours. So they did this large study, 100 patients. They defined reflux as acid exposure time greater than 6%. And they found, I think, a very important finding as far as stratifying patients with GERD. They found that if you did not have any GERD over the 4 days, then basically 67% of the patients were able to get off of PPIs. And with a little bit of coaching, were able to stay off of PPIs. If they had a GERD for only 1 day, about 50% were able to get off PPIs. But if you had it for greater than 2 days, you really did have acid reflux disease, and you were only able to get off the medication about 21% of the time. This has been a great advancement in our stratification for patients with GERD. Now, this is a young lady, I must admit, she was in one of our original Bravo studies, but you could see her wearing her Bravo probe going to the movie, if she happens to be a teacher teaching in her class, something like that, it's much more comfortable to wear. This is her little device that she has, the radio receiver down here that she carries on her waist. And actually, that thing stays attached to the esophagus probably about 80% of the time. We still need the transnasal probe, though. We have not been able to rid ourselves of that. And that basically is used in testing esophageal impedance pH monitoring. A transnasal probe allows you to measure the flow up and down the esophagus of any type of fluid, regardless of its pH. And then throughout this pH, throughout the system, you have pH probes, one in the distal esophagus, one in kind of the lower 2/3, and oftentimes one up in the upper 2/3, depending on what type of system that you have. It also allows you to measure air, which is of some interest to some people because of the fact that air results in a positive deflection, whereas the reflux of food is a negative deflection. Now, the surgeons have always said to us, you guys think you're so great with your PPIs, but you're really not doing it with anything with your proton pump inhibitors. What you're basically doing is just changing the setting that the patient is refluxing in, and they're absolutely right. But they've actually shown us that basically non-acid reflux or weak acid reflux is a pretty benign state. So here we go again. So here, when you're measuring impedance, you're no longer looking at acid exposure time. You're looking at total number of reflux episodes, 80 being normal. And red is acid reflux episodes. Blue is acid reflux. Green is non-acid reflux. And you can see the results of being off of a PPI and the results of being on a PPI. And it would be just magnified if it was a surgical situation. So again, the surgeons are right. Basically, PPIs do not eliminate reflux, but they just change it to a non-acidic form. The good news is the non-acidic form is not injurious to the esophagus. Now, here's what an impedance pH tracing looks like. Over on the far right-hand side, you have the impedance. The impedance is electrical measurement. It gives you a baseline value. On the bottom, you have the pH that you can measure, and you also have a recording of time. And then you can measure both reflux episodes and food or other things being ingested. Reflux episodes tend to be longer in duration, and this is a reflux episode coming all the way back up into the proximal esophagus. May even be associated with regurgitation, I don't know in this case. And then this is another short episode of what might look like reflux to the novice, but actually is a swallowing episode. Now then, when do you use pH testing versus when do you use impedance pH testing? A controversy that was really quite hot 10 years ago and no longer is probably as interesting as it used to be. If it's a low probability of GERD off of PPIs, if they have atypical symptoms, if they have extraesophageal symptoms, if they have normal endoscopy, if they have previous failure on PPIs, best to study them off of PPIs. You want to make sure they have acid reflux disease. And then you can use any type of methodology that you want to use. I prefer Bravo pH testing, and as I mentioned, I prefer using the 72-hour technique. And in fact, what we find is 75% or more of these patients are totally normal, and therefore we need to go no further other than, psychologically work with them or get them to see a psychologist in our clinic. And by the way, psychologists are being used more and more in GI clinics. If they have abnormal amount of reflux, then we move them over here to the area of studying them on BID PPIs. They may have classic symptoms like regurgitation symptoms, and also a very common place that we use this at South Florida is in our pre and post lung transplant patients. And then in these patients, they're studied on BID PPIs. And then when they're not getting better, uh, we know that we're dealing with non-acid reflux, and non-acid reflux is of interest in certain areas. It's an interest in classic symptoms, but it's also of particular interest in lung transplant patients before and after, because it's not so much the non-acid that's dangerous, but it's the stomach contents, and the stomach contents contains bilirubin, and bilirubin is very dangerous to the surfactant of the lung. Therefore, you don't want your lung transplant patients to be having reflux of surfactant during the after they've had a successful lung transplant. Well, here's another consensus report. Now, this is by a younger group of gastroenterologists, so I wasn't unfortunately invited to this one, and Lyons, France, done about 2 years ago. It's also kind of updates us on basically the our various thoughts about reflux. Number one, atypical GERD symptoms. It's now included belching is a variable that's most likely related to GERD. Cough is not, and hoarseness, globus, nausea, pain have no relationship. These are things that we've known for a number of years, but this has kind of given us a little bit of a stamp of approval. We now include LAB as one form of our esophagitis. It used to be just C and D. Now it's also LAB is a strong evidence of esophagitis. And if you endoscope a patient and they have B, C, or D, then you've made the diagnosis of GERD. 96-hour pH off PPIs is the preferred diagnostic test for unproven GERD. The acid exposure time for 2 days is greater than 6%, then they have GERD. If you're doing impedance monitoring, then off PPIs, an acid exposure time greater than 6 and a greater than total 80 total reflux episodes supports the diagnosis of GERD. And then if you take that patient and monitor them on GERD, BID PPIs, then the acid exposure time should fall below 4, should fall within normal limits, and the 80 reflux episodes will basically stay. And then, interestingly, we've noticed that at night there's a nocturnal impedance that falls if the patient has GERD. And I hope I can do this with this computer. But if you notice here, some of this is at night. This is impedance. And it drifts down at night if the patients have GERD. So it is another manifestation that the patients have gastroesophageal reflux disease. Okay, so we've talked about how common this disease is, the symptoms the patients is. Now let's get into treatment after we've talked about the diagnostic test. There's over 100 relevant tests, but at least when I looked this up, only about 16 clinical trials. Many food products are not associated with lower or esophageal sphincter changes and are not associated with long-term reflux. The one thing which is proven to be associated with long-term reflux disease is head of the bed elevation and left lateral decubus position. The left lateral decubus position puts the gastric bubble away from the esophagogastric junction. And you used to say, well, how in the world could you do that on a patient? They can't sleep on their right side. Well, the answer is they can now with these various types of little fanny packs that they have that are commonly used by patients who also have a sleep apnea. Weight loss obviously improves pH profile and symptoms, and tobacco smoking cessation reduces reflux in normal weight patients. Now, here's the best study we have to date of the importance of weight loss in patients with reflux. This is the famous nursing study going on for 20 years, and it shows at 20 years there's a fourfold increase in reflux disease in the patients that put on weight. So weight gain is a very important aspect of reflux disease. Now then, these are 3 slides that I borrowed from Peter Carrillos, but I think they're very interesting slides because they show you the potency of these medications versus the potency of the disease. So here you have on the bottom, you have the potency of the disease, you have severe and mild, and you have the response, whether as compared to placebo. Here you have the maximal therapeutic response over on the right-hand side. You have basically, you could have a maximal response compared to placebo of 0 to 100%. And to use as an example, here's heartburn, basically a 10% therapeutic response. Here's the H2 blockers, 20 to 30% therapeutic response. If the disease is relatively mild, then it's on the high 30%. If it's relatively severe, then it's more like around 20%. And then you basically have esophagitis and the PPIs. And basically, regardless of whether or not it's mild or as shown maybe in the green cross or severe esophagitis, these patients get better. Having been one of the original PPI investigators with omeprazole, I can guarantee you this was a miracle drug. Now then, let's look at NERD. Now, NERD is a problem because with NERD, we never know how many of these patients really have GERD and how many of them are just acid sensitive. So now we've got the same thing. We've got mild and severe disease. We've got placebo on the bottom, and we've got therapeutic gain. And now here, rather than, since we don't have any esophagitis to look for healing, we're basically looking for symptom relief. You can see with various doses of omeprazole and rabiprazole and esomeprazole, you basically can get complete relief in a degree of patients, probably in the range of about 20 to 30%. And you can do better. You can get adequate relief. In other words, where they quit visiting the emergency room or quit bothering you in about 40 to 50% of patients. Now then, let's look at heartburn versus regurgitation because they're actually 2 different diseases. Now here's the same therapeutic gain diagram. Now we're going to do heartburn. You can see heartburn, and you can see basically the goal average, the range up and down of the PPIs, and then you use the PPIs and regurgitation, and it's all over the place. And it's all over the place because a lot of things would cause regurgitation. Regurgitation could be caused by basically rumination. It could be caused by GERD, but it's more of an anatomic problem than it is an acid-induced problem. And then here's another way of showing this. Basically, you know, esophagitis, mild esophagitis, severe esophagitis, the therapeutic gain, heartburn, mild, and the more severe regurgitation, chest pain. If you choose the right chest pain patients, then you'll have remarkable responses. And then you get down here to the other forms of PPI-associated disease where it's kind of unpredictable, and you end up trying it or doing pH testing. Now, this is the newest of the PPIs, and this was a new form of a PPI known as a PCAB, thought to be a little bit stronger than traditional PPIs. Came out of Japan, and they really were quite excited about it. This is a study just published in the New England Journal by Lauren Lane and colleagues, and it uses 2 doses of vasopressin, which is the newest PCAB, versus placebo in non-erosive GERD, and it's a 6-month study. And you can show that basically in the first week or so, there is a difference between drugs shown in purple and I'm and the I'm sorry, not drugs shown in purple. Basically, placebo shown in purple and drugs shown in 2 different colors. I can't make out both colors. And you can show that at one week there basically is marked improvement as compared to placebo, but by 4 weeks or by a month out, there's not any difference. So is that going to be a big factor? I don't know. The Japanese are making a big deal about it, but we'll just have to find out. Now then, you might ask, well, if the problem behind all this is really the transient lower esophageal sphincter pressure, why hasn't there been more studies done towards that? Well, there's actually been several drugs that have been proposed, and both groups decrease reflux events and acid exposure about 40% in controls and GERD patients. However, alone or with PPIs, they add little to treatment of refractory GERD. Therefore, basically all clinical studies have been suspended, and we may still occasionally use this when we're treating persistent regurgitation or excessive belching. What about PPI responders? Are there really people who do not respond to PPI responders who have some form of GERD? Well, the answer is yes. Everybody who has doesn't have a response to BID PPI needs an upper endoscopy. About 10% of them will have something else. Pills and probably eosinophilic esophagitis are the 2 most common other things that they have today. Some older women will have a lichen planus, which we wrote about in the annals about a year ago. Now, 90% will have a non-esophagitis, and it's those patients who you want to do pH testing of one sort or the other, and you find that they have persistent acid reflux, they have weak or non-acid reflux, which we've already said is not very dangerous. They have a sensitive esophagus, that's a form of an esophagus in which acid reflux is up a normal amount of acid and causes symptoms. And then the diagnosis is just flat wrong. Maybe they have achalasia or gastroparesis. And now part of this is just because there's a spectrum, and this was found in another one of these meetings at a nice location. That is, there's a spectrum of esophageal sensitivity to acid. There's acid exposure, and there's esophageal hypersensitivity to a normal amount of acid. Bad acid exposure and bad acid clearance gives you acid esophagitis and NERD, and reflux hypersensitivity and functional heartburn gives you basically these esophageal hypersensitivity syndromes, which don't do well with PPIs and don't do well with surgery. Now, what are factors that maybe are important in reflux symptoms? Well, the extent of the reflux, how high it goes up, how large the drop in pH is, Do they have a baseline low nadir NIH to start with? Do they have poor clearance? Clearance is a really important aspect in reflux disease. Do they have a mixture of gas with liquid reflux? And are they hypersensitivity to normal degrees of reflux? Well, what about some of these consequences of PPIs? It seems like PPIs have been associated with all types of side effects over the years. Uh, First time I had my attention brought to this was I got home and my wife said, "Do you know these drugs that you're using are causing a four-time cause of dementia in patients in Germany?" Well, it turns out when the study came out in neurology, there were 70,000 patients with dementia. They were on regular PPIs, and so they were controlled. They were somewhat controlled for that, and there was an increased hazard ratio of 1.4 uh, with an overlap. This is actually a relative acid, a relative risk of 4%, but only an absolute risk of about 1%. Now, there's also a better article that came out in the American Journal of Gastroenterology in 2017. One of the problems with these articles is there's so many co-founders that make it very difficult to find out what is really right. And there's really been no good placebo-controlled study to show any safety issues. But in this study from Finland, nationwide study, 70,000 with documented Alzheimer's, it was a nested control study, so they had various communities that were on the drug and others were not. And the PPI use was confirmed by the National Prescription Records, so they knew they were taking the medication. PPI use was only associated with Alzheimer's risk in a very small percentage of patients in a 3-year lag window. In other words, the longer you were on the window was no. So basically, there was no real effect. And this is one of the things you deal with these hazard ratios is basically they're interesting for developing hypotheses, but they're not very interesting for making definitive studies. So yes, if the zone of interest is 3 to 10, well, you got a 30 to 100% chance of uh, of uh, having, a relationship between the disease. But when it's down, particularly in this potential bias area, which most of these studies are, really they don't. And then there's certain drugs or certain things that are protective. Now, what does this mean for the internists in the audience? Well, what it means is basically once a PPI, not always a PPI. If they have uncomplicated GERD responding in PPIs, then you ought to stop, switch the H2 blocker, switch to an H2 blocker and reduce or put them on the lowest dose of a PPI as they can. If they have uncomplicated GERD but are unable to stop PPIs, then they should have esophageal pH testing to really ensure that they need to be on lifelong PPIs. If they have the complications of reflux disease, then basically they need to be on lifelong PPIs. They probably ought to have a chronic check of PPIs, see if they're having any trouble. And at least at this point in time, there's been no real complications associated with PPIs. There were initially some problems associated with them with the bone disease, but that does not seem to be the problem at this point in time. Well, the surgeons really haven't gotten out of the business because they have the way of really fixing this problem. That is, they can take this hiatal hernia and get that back down in the abdomen, reduce that, and use this fundoplication to kind of tie around this hernia so that it doesn't regenerate. And there are people who want anti-reflux surgery. They desire a possible cure. They preference or fears of PPIs long term, or they're intolerant to PPIs. Some of them have failed medical therapy due to persistent volume reflux. Some of them have recurrent peptic stricture in young patients, and respiratory complications may be a factor in some of these patients. Now, the best patients for anti-reflux surgery are the ones who have large hiatal hernias, a large amount of acid reflux disease, and heartburn and regurgitation. This is shown nicely in a study from the group from Vanderbilt. Now, surgery works. There's no question about this. This is a 5-year study comparing surgery to esomeprazole. So it's kind of a choice type of a situation these days of which one you prefer to choose. The only place that's probably not a choice any longer is what to do about the bariatric patient. It used to be we would do anti-reflux surgery on the bariatric patient and still operate if nothing else worked. But now we would rather do the bariatric surgery than we would the reflux surgery because of the high recurrence rate. Here are complications associated with surgery. Surgery associated with mortality, especially if you have to revise the surgery. There's chronic postoperative complications shown here, dysphagia being most common. And about 2 to 5%, 15% of these patients need repeat operations. Now, as a result of that, there's been several kind of very interesting devices developed. First of these, and the one that's been the keeper, has been this technetium bracelet, which is going around the esophagus. And the idea behind that is the technetium bracelet kind of closes when you're not eating, and that kind of causes a artificial sphincter, and you don't have reflux. And then when you eat, the pressure being generated by the food bolus going down is enough that the valve opens up. It turns out to be very effective. I'm shown on the left slide is the 5-year study, and there's now a 10-year study coming out looking at 100 patients at 5 years, and 84 are available for follow-up, and you can see how many of these patients no longer have reflux and how few side effects that they actually have associated with this. This is also a study looking at the LINX procedure versus double dose PPIs for regurgitation in GERD in a randomized controlled study. It's a 2-to-1 randomized study, PPIs and the surgical procedure. And you can see that the device cuts down on regurgitation, improves the quality of life and the satisfaction of current conditions. And it also by all measures cuts down on the amount of regurgitation that they're having. Now, there was another idea that was not quite as successful. This was the idea of maybe developing a sphincter, which you can do endoscopically or you can do surgically without a surgical scar. And you have a kind of a funny looking surgical endoscopic device, and you put in these pledgets, then you develop a new valve like shown here. Well, here's the problem is it seems to work fine the first year or so, 2 years, and then it begins to wear out. And the problem is these pledgets are put under a great deal of stress, so it's very difficult for them to be able to withstand the coughing and the bending over and the various things that they do. So this device has not actually worked out. So I think that's the last of what I have to say. I apologize for the computer problems that we have, but hopefully you got my message across, and I'll be happy to take any questions that you might have.
Well, thank you very much. We'll turn it over to Dr. McLean, there he is in just a moment. But I always have to ask the obligatory chair's question about nutrition, of course. Uh, the food triggers would be a whole nother probably lecture. But the reports in the literature say that a whole food plant-based diet, because it's low in fat, rich in fiber, rich in alkaline foods, and has anti-inflammatory properties, can be a big solution for many of these patients. Have you had much experience with that?
I have not had any experience with that. I mean, that came about the time I was retiring. But I mean, I think it makes sense that there's certain things in the patient's diets that if they could eliminate those things, that would be enough to take care of their reflux disease, particularly the ones who have non-erosive reflux disease or have reflux disease not associated with the low valve pressure.
I see.
And kind of in a similar vein related to nutrition. So a lot of our patients in Kentucky are overweight and with reflux. And so if you have a patient that can't lose weight, what's your approach to the overweight patient with reflux?
Yeah, Craig. That's the same approach that you have. I mean, you behead them. Um, that will help take care of that problem. Or you offer them in all seriousness, one of the things that we've really learned in them is that bariatric surgery has a lot more to do with an effective anti-reflux procedure than a basically anti-reflux procedure. By by reducing that intra-abdominal pressure and the other factors like that, you basically cut down on the reflux that they have, and your death mortality rate is not as high as if you used to use a more aggressive approach to them.
Okay.
All right, real quick, and we do have a couple of questions in our chat area, and I will read them for you, Dr. Richter. First question comes from Dr. Dawn Castor. She's an associate professor in our nephrology group, a division, and she says there have been confounding studies showing an association between PPIs and chronic kidney disease. What are your thoughts on this? And she says, I often will try to change from PPI to H2 blocker, but many patients have worsening symptoms when this is done.
Yeah, that's a superb question because it is the only complication I have seen with the PPIs. And I thought the story was that there was a large um, lawyer group in Canada that was going to pursue that. The basis behind that is it's well known that PPIs will cause an acute form of interstitial nephritis, and that basically what's going on is that they're causing a chronic form of interstitial nephritis, and that's what's giving you your chronic renal failure. But at least, that was I followed that over the last half dozen years, and that so far has not gone anywhere. And I don't think there's anything wrong with the process that this physician is doing. All the PPIs being equal, changing them periodically is not a bad idea at all. But you still have the PPI factor.
All right. Another question. This comes from Dr. Robert Emmons. He's in our hematology oncology group, and he wants to know. He says, "Can you comment about oral changes and respiratory changes from reflux disease? Do those issues mandate surgical correction?"
Okay, do the oral and well, I'm not sure what he means by the oral manifestations associated with reflux disease, though it is well described, and we described it, 20, 25 years ago, dental erosions associated with acid reflux disease. It's no question that acid reflux disease in a certain group of patients can cause chronic lung disease. It does that by the fact that the stomach contents, particularly bilirubin, have an effect on surfactant. And depends on what transplant centers you're at. But at South Florida, basically all of our patients had impedance pH studies before and after their lung transplants to see if we effectively controlled the quote non-acid reflux disease as well as we did the acid reflux disease.
All right. We have a question from Hussam Sarakbi. He is our chief of rheumatology, and he wants to know, can bariatric surgeries cause GERD?
Can bariatric surgery cause GERD? Now that's a good question. That's a GERD question. I assume anything can cause GERD, but the answer is our current thought is the vast majority of people do not have as much trouble with their GERD after bariatric surgery. Can it cause GERD? That answer I don't know.
All right. And I guess our last question, actually, Dr. Emmons has one more. He wants to know, how has semaglutide affected weight reflux differently? Is the benefit directly related to weight?
I'm sorry, I didn't catch the first part of the question.
How has semaglutide affected weight/reflux differently?
Is this the various types of drugs that they're using, the injectable drugs that they're using?
Parent,
That this is the weight loss drugs like Ozempic,
Ozempic.
Right.
GLP-1 agonists, how they affect.
Right. Yeah, I would suspect that they affect reflux by reducing hiatal hernias and reducing abdominal adiposity. Those are the major ways that they're doing. Are they going to make reflux go away in these patients? Well, while they take the medication, they'll go away, and then afterwards. In fact, I was surprised whether or not it was an ad I was watching last night or not, that some of these people had as much as 50%, had as much as 50-pound loss, weight loss. So that was really quite dramatic. I think I'd have to have a discussion with the patient about that situation and everything.
that's all from the chat area. So.
Well, fantastic. Really, thank you. Final words of wisdom, Dr. McLean?
No, it's a big problem, and we appreciate Dr. Richter's insights.